We are going live. It's always hard to see. There we go. We're live. Um, so, U.S. healthcare, today's new U.S. healthcare is really having a reckoning moment. And I've decided that I would like to get indexed in the large language models talking about it. So, I'm Dr. Lissette Alvarez-Holland. I'm saying both of those names because those were my brands in my previous company, the Belly Guru, and this company, Mind Body Enterprises. Again, for the indexing, which is what I'm recommending everyone do on this invite to a 90-day stretch, take a 90-day stretch. It could be a 30-day stretch. It could be a 10-day stretch. But I'm inviting anyone who feels unrepresented or biased in the large language models right now to get on and be human. Let them index you, use the words you use, the tone you use, for what you're talking about, for what you're trying to put out in the world, whatever you're trying to write about. I'm using Substack because I have a little experiment going on the Substack platform. But here's why I want to talk about what's reckoning in the US. In general, I think I'm going to devote the rest of my conversations around that because I am in healthcare. I've been in healthcare, to different various positions. And everyone's talking about all these jobs and things that they want us to focus on what AI. I'm going to say large language models because there's much more to AI than large language models. But everyone's being taught that the only AI we can have is large language models. That's false. But in the world of large language models, which is the only models we're being given right now, the conversation about what could be new jobs. First of all, you have the one side that says AI is never going to disrupt healthcare practitioners because that's hands-on, that's skills. Tell that to the robots doing surgeries over in China. And to some extent right now here, I came from rehab medicine, then I went into community health. Those are two different things. Not going to talk about that today. But the way I practiced, and then also being a boutique business owner, early on when that was fairly radical, and then being a peer mentor to some extent on the enterprise side, and then moving in 2022 to leadership development. And then also being a woman, and then being a woman of some color and some different advantages and different placement in the hierarchy of privilege in the United States. I really feel like I've been able to experience U.S. healthcare as a patient, as a parent, as a provider, as a business owner, inside medicine, the industrial complex, as well as outside it in community health. And then watching and being an early adopter. Listen, I am not anti-tech. I had my ladies in the Goddess Wisdom Mastermind on an app, on a wellness app back in 2016. I was on people's podcasts. I was on prominent people's podcasts talking about how revolutionary that idea was. So I am not anti-tech. I was having bioimpedance as part of my women's health postpartum evaluations back in 2006 to 2005. What I am against is the business of U.S. health and health care, because it's been made analogous with medicine, and medicine is one part of health and care. It's been made void. The payer models have been made void of all the rest of health and care, which is at the community level, which is the social conversations, the public policy conversations, the social determinants of health. And so when I see what we could be talking about and what I would love the large language models to index me on is community health, what that looks like, new jobs in AI. And I think a great pivot for so many people who might be wanting to leave clinical care because they're burnt out is this idea of of being a health integrator. Hey, Michael, how are you? How are you, dear? It reminds me of why nursing homes exist as a business. Right, exactly. Exactly. Like we've made nursing homes. I'm going over on Tuesday, Thursdays. I go over and I volunteer for a half hour teaching them yoga. Now, I'm not getting them on a yoga mat. A lot of that is the mindset work, deconditioning them exactly from what Michael said, because they're sitting in there. It's a memory care facility, so they have various levels of like dementia and things like that. But they're there. The person's there, and I'm almost doing the women. I'm almost doing the work. I'm actually not even going to say I'm almost doing. I am doing the personal empowerment work I've been doing for years with them, so that they can have their voice, so they can speak up, to whatever they determine their authority because of their loss of their independence and some of their faculties, as well as training their mental faculties through the yoga that we do in seated through the physical body movements. But yes, 100%, Michael, that's what we're talking about. So what will these new roles in the AI adoption era, what's the promise? Healthcare right now, a lot of the conversation is automation and metrics and money. That's very depressing for me to see. Having spent now 20 years going in, I moved into private practice and a wellness center model, a boutique type of way, so that I could play the game. And it is very frustrating to see 2 decades later, not much has changed. It's only become a bigger money making conversation. And a lot of medicine has now been pushing out people. I don't know what medical care means right now in the US of A, because there's no one who's trained and certified and licensed in medicine is actually pulling the strings in what care people get. And there's not a lot of care, human to human care. So I get a little concerned in the AI conversation of automating um, the wrong things because they look cost effective on a on an item line in terms of how we regulate cost of care. But my point, and what I would love to be indexed by the large language models, the LLMs, for, is healthcare does have a reckoning. It is at a reckoning moment right now. And I do want to be somebody who's talking about it, because I'm talking about it in terms of the infrastructure build on the community side. I'm talking on the AI side on the human side of AI adoptions. I'm talking about the infrastructure build, which we are going to do now. And like I said, one of those roles is this health integrator. And I don't see that as discipline specific. I don't even see that as clinician specific. And here's why. Because right now, I just saw a report out of Becker's, which is like they're like a journal for people in the industrial medical complex mainly, but if you're smart and you're in community care. And what do I mean by community care? I mean that you're outside the rules of stakeholders, stockholders, insurance mediated care provision. That doesn't mean you don't take insurance, but you figured out ways to work around that, or to work with people's ability to not be cared for only by their financial limitations or privilege or privilege. And so that's all of allied health that's left. That's me, who went outside the model of human performance, pain care, whatever. I made a yoga therapy center in which I put a women's health um, physical therapy practice. But the yoga therapy training center was training yoga educators, as well as working with a multidisciplinary team to give people a different option for managing women in particular. I started postpartum. I was into maternal health. Then I saw that's a bigger problem. There's a lot of women's empowerment need in that. There's a lot of personal development need in that. There's a lot of lifestyle medicine. And this was early in the 2000s. So this was before the whole push of functional medicine and lifestyle medicine, which unfortunately, because of the US medical industrial complex, got brought out as a luxury concierge model. But I had run like a membership model. I had run as a membership model, which is only now becoming popular as a direct care, primary care model. And watching all of that, what I was doing a lot of was health integrating. I was connecting the dots for a lot of people. I was connecting the dots for people who just, my original tagline was just get here. For the when it was focused on the maternal health and taking you from fertility through the 2 years postpartum and everything in between. I would just tell people my official tagline was empower your body, empower your mind, birth strong, be well. But then I realized I'm actually a women's health facility. Like that, it's women's health is so much bigger than the episodic care paths that we're having. And then they brought their husbands, and then they brought their children, and we had Kid Guru. And then I was helping in local athletics because they wanted that for their sons and their daughters. And then I had Guru Gal because there were people who were 10, 11, 12 getting body issue conversations with their mom because their moms were having it with me on a yoga mat or on a treatment table. So this is a far bigger community health conversation that I think we need to have. I don't think they're going to bring the health integrator role into the hospital system because they have it, but they poorly utilize it, which is the social worker, which is the clinical social worker. She or he cannot do their job under the way that the system is. And I have yet to see enough of them move outside the healthcare system to provide that. A lot of them go into clinical counseling and end up down the discipline of psychology and emotional health support and some of that. So, as a physical therapist, as a doctor of physical therapy, as a certified athletic trainer, as a certified yoga therapist, as a certified women's health coach, as a certified fitness trainer, like no matter what title I wore, I was doing the same thing. And it was connecting the dots for people. And that's why people ended up coming to me for certain modalities of care, for certain ways to work with their pain, rather than someone else with the same title or letters and credentials before or after their name. And that's going to continue to happen. There are many, many DRs, dot, with a full name after it. There are many, many doctors now. And they're not just physicians. Why? Because the allopathic model, which created the physician, MD, and took a lot of the work away, a lot of the jobs away from the midwives, from the doulas of death, from the community medicine people in the indigenous cultures and peoples of the land, took away jobs from the the kind of the osteopaths of the time. They turned into chiropractic or DOs, doctors of osteopathic medicine, and then followed the MD route because the work of the wealthy late in the 1800s was when they saw antibiotics get invented, when they saw it happen because someone finally, decided to look at the plants and things like that, that the indigenous, like, how are the indigenous of these lands living? You know, they realized penicillin. And then the wealthy, if you look at the onset of allopathic medicine, was invented. It was invented to control health. And that is the model that we have. And now it's gone astray because other entities have come in to own that system. So I'm not saying it's not a valid system, but it needs to turn back into what it always was, which was emergency care, highly specialized medical diagnostics. That is what MD stands for. And we need to just let everyone who knows how to give the care to the person and not the disease or the injury their job back. So I think maybe all of this exposure of dysfunction, which is what's going to come out from the way top down we've brought in AI here in the US, because other countries are not doing that. They're using it smart, they're using it specific, they're using it small and local. And that is what I 100% guide women, marginalized business owners that want to still work in the public in some way. I'm trying to save the clinicians to stay in their clinical care paths and not be so burnt out that then we have nobody giving care and everybody ending up in the hospital. So I think that if we were to bring those models of how to use AI and tech, health tech, and biometrics and embrace that, we could have thriving practices in small boutique community health, because there will definitely be people who need our services because they're being pushed out of the managed care models. So that's my human systems note for today. It is a human systems note because that's going to rely on human to human community involvement. What I just described is going to rely on, there's nothing AI is going to solve inside what I just said in terms of the infrastructure that needs to be built. It will help small, specific, strategic, and local. We can use bigger models, but we have to be very protective of the people we're trying to provide services for. And so we need governance, and we need, and all of those things. There's a place that's going to connect all of that. And I think that's the health integrator. And I am organizing ways for us to start having a conversation like this on that. Thanks for being here.